more. No more. Hello. My dog was trying to come in. It looks like I'm live. Is anybody here? This is in stream. Okay. I'm going to share this with some people. I'm going to get on myself. So guess what we're doing today? I'm so glad to see you. There's nobody, but I'm going to record it. So that is perfect. We're going to record the entire screen. Here we go. Share it. Okay, I'm going to pause for a moment. Before you do anything else, read the question. Okay, read the question. It narrows your focus. Here we're saying, which antipsychotic is the best choice when considering efficacy and this patient's comorbidities? Okay, whenever you also see this patient, that's a big sign that you need to go back, probably. You need to go back just to be safe. Even if you think you know the answer, don't skip the patient profile if it mentions in the question, this patient. Okay, because we all know that sometimes they give these questions and there really weren't any reason to go back to the question. So I'm trying to send some people the link here so they can get on. And hopefully we did it. So then we have the antipsychotic that's best choice. Go back down, scroll through the options. If you notice, all of the options are antipsychotics that they're talking about. Okay. We're looking at different ADRs, basically. To me, it's looking like maybe we really don't need to go back to this patient case. But just because it says this patient's comorbidities, I'm going to look back and take a look. Let's see what they're talking about comorbidities. Bipolar disorder, type 2 diabetes, obesity, dyslipidemia, hypertension. Currently, decreased sleep, pressured speech, impulsive spending, and agitation. Okay, let's go through. Treat each one as a true and false question. So the best way to do select all that apply questions would be treating each option as true or false. You don't compare between them if it is a select all that apply question. But when it's a multiple choice question, you can compare between them. We'll have some other questions that show us what I'm talking about with the comparing them in the multiple choice. So A, let's think of it. Is this true or false? So olanzapine, is that the best choice for this patient? Because it has a strong anti-manic efficacy and rapid calming effects. So at that point, you're going to say, is this true or false? If you think it's true, if you think you feel 60% sure of it being true, then you would mark that one and then go to the next option. If you don't feel 60% sure or more, don't choose it. Let's go to the next option, clozapine, because it is the most effective option for mood stabilization. We might want to think of different reasons why we don't use clozapine and check the patient's past medical history. Quetiapine, because it treats bipolar disorder and has no metabolic monitoring concerns. That sounds iffy. Whenever I see something that's all or nothing, I don't like the word no metabolic monitoring concerns. That just doesn't hit me right at all. So pay attention to those flag words, red flag words. D, ziprasidone, because it's effective for acute mania and has lower metabolic burden. It sounds very plausible. So I might mark that one and then go to the last one. E, chlorpromazine, because it avoids QT prolongation and metabolic adverse effects. So enter in the chat right now what answer you think it is and why. Enter in the chat. I'm entering for myself. It's D. Let's go to the next slide. Ziprasidone, because it is effective for acute mania and has lower metabolic burden. I'll show you some tricks to remember why. Here we go. Remember how the question had olanzapine and clozapine in them? Olanzapine, clozapine. Well, quetiapine also has metabolic burden. Why did we not want metabolic burden? Well, the person had type 2 diabetes and obesity and dyslipidemia. So those are some huge reasons. Actually, put those together and we have metabolic syndrome right there. Increased blood sugar, obesity, and dyslipidemia. So that's what this question is all about. Which drugs are the worst as antipsychotics for metabolic risk? So second generation antipsychotics in general have more metabolic disorder symptoms. The following are second generation antipsychotics with the most metabolic risk: olanzapine, quetiapine, clozapine. And get this, this is how I do it. O for olanzapine, Q for quetiapine, and there's a C in his head for clozapine. And they rhyme. They have the worst metabolic burden. We also have risperidone, paliperidone. They rhyme. And I say it like that, own, to help me remember this big belly. So this is a person. So the big belly is the O for olanzapine. The belly plus his leg is Q for quetiapine, and the C in there is clozapine. On the other hand, we have a skinny girl. Here is my picture of skinny girl. This helps me to remember which drugs have less metabolic risk out of our second generations. So we know that first generation actually has less metabolic risk than second generation, general rule. So first generation antipsychotics have less metabolic risk. Additionally, the following are second generation antipsychotics with less risk. We have two A's, aripiprazole and asenapine. They come as sublingual and patch for asenapine, Sequado, and Saffris. And so aripiprazole and asenapine are generic names. Can make a dress and maybe her slip underneath, two A's. Lorazepam would be L for her legs. Lorazepam is Latuda. Latuda should be taken with Fuda, at least 350 calories. So that's her legs. Remember, this is our skinny girl. But our skinny girl has this great frizzy hair up here. Here's her hair. That's Z for ziprasidone. So to reiterate, ziprasidone was the best for that patient. It's effective for acute mania, and it has lower metabolic burden. The end. That was it. Okay, we'll get through this next one quicker. And if anybody's here, go ahead or type in the chat, say hi, say hello to me. I'm going to be my own top fan there. Case 4, which counseling point is most accurate? So we go to the question first again, and I'll give you a moment to look through the question, zoom in on your end if it's needed. Okay, so we scan through our options. And so the question is very generic. It's like, which counseling point is most accurate? It doesn't give us a lot to narrow our focus. So let's look through the options. It's talking about valproic acid, folic acid, valproic acid, fetal risk, lamotrigine, and liver. It's talking a lot about fetal risk and pregnancy. So now I'm narrowing my focus. So enter the answer that you believe is correct. Okay, see, is that right? Valproic acid is associated with neural tube defects and neurodevelopmental impairment. And Shai, you are so correct. So correct. Let's go through these options. Could you tell me why A is incorrect? Valproic acid is preferred because it is the most effective medication for generalized seizures. That's just not true. We tend to use multiple drugs at the same time. For seizure, it takes more than one drug often. B, folic acid supplementation eliminates the fetal risks associated with valproic acid. Shai, what do you think about that? Folic acid supplementation eliminates fetal risks. How could you already told me you think that's incorrect. How could you make it correct? How about that? As you're working through problems, if you do that and try to form correct statements, it really does help the processing of the material. Maybe you would say folic acid supplementation reduces fetal risk associated with valproic acid, and actually anybody of childbearing years should be on folic acid supplementation with seizure medications, all of them. Lowers, I agree. You said lowers, and I agree. Let's go to E. Lamotrigine and levetiracetam are contraindicated in pregnancy due to higher malformation risk. You said that's not true. What is true about in pregnancy are L drugs? I'm going to type it in, L drugs. Lamotrigine and levetiracetam. Shai, what are the brand names? Lamotrigine and levetiracetam. You know these. Capra, correct for levetiracetam. It says to lay down. I think there was a typo there. Instead of lamotrigine, lamictal. Definitely looks like a typo. Lamictal would be the correct answer. Okay, so the key trap here was seizure control matters, but valproate is one of the highest risk options in pregnancy. We don't want to give valproic acid. It's associated with neural tube defects, and pretty much everything else except our L drugs are also contraindicated in pregnancy. They're teratogenic. What do you say we do case 5 and then we can wrap it up from there. Hey, it looks like other people are actually on here. Hey, if you're on there, say hi. Wave to me. Oh, your internet connection was messed up, so you missed part of the question. Gotcha. Okay, we are on the next question, though you did a great job with the previous one. Hi. Okay. I hear myself delayed, so it's really embarrassing. Screen blurry. Let me see. Why is it blurry for you? Maybe I can redo this. It looks it does look blurry. I close out of some of this. Maybe that could be it. We'll get it eventually. I mean, this is the second time I'm trying this, so hopefully. Oh, it still looks blurry. Okay. Okay. Let's see. Are you there? How is the screen now? Is that any better? Yay! Okay, we can see it clear now. Okay, here's our last question. I promise if we do it every day, I will get better at it. Which medication is most appropriate? Okay, again, the question didn't narrow our focus. You are welcome. Haloperidol, because it's effective for hallucinations and has minimal anticholinergic activity. Who thinks that's right? Say yes or no. Everybody say yes or no. Haloperidol, do you think it's haloperidol to be appropriate for a patient because it's effective for hallucinations and has minimal anticholinergic activity? I can tell you for this statement, you should be able to answer it without even looking at the case. I'm sure we will need to look at the case, but we should be able to answer to decide whether A is correct or incorrect just based off of the sentence. Who thinks A is right? Who thinks A is wrong? Okay. Me too. I'm going to say no to. How about B? Risperidone, because it is less sedating than quetiapine and lowers fall risk. We know that quetiapine is very sedating, right? Lowering fall risk, maybe now might be a time to take a look, because to get a better idea of what we actually need to do to be appropriate. So let's go ahead and scan the patient profile. I'll give you a minute to do that. Blow it up, make it bigger on your end. Patient is a 76-year-old male, no known drug allergies, does have Parkinson's disease, okay? BPH, mild cognitive impairment, orthostatic hypotension, 3 weeks of visual hallucinations and paranoia, no fever or infection symptoms. We need to, as a goal, treat psychosis while minimizing worsening tremor and rigidity. Patient is already on carbidopa, levodopa 5 times a day, entacapone with each levodopa dose, and amantadine. We talked about these in class, all of these the other day. And the patient for BPH has tamsulosin. Scrolling down here, blood pressure is a little low, not too bad. Standing though, definitely orthostatic hypotension. QT is within normal-ish, right? Ish. Sodium is good, serum creatinine is good. UA is negative, no new anticholinergic medication. Is B correct based off of what we looked at? Is risperidone going to treat psychosis while minimizing worsening tremor and rigidity? If you had to choose an antipsychotic for somebody who had Parkinson's disease, we want to choose the one that has the fewest EPS symptoms. And there is one that would be preferred in Parkinson's disease, and that's quetiapine. So I think of quetiapine quiets the minds and the movements. So it has the least EPS, but it does still have risk. And it still is a dopamine antagonist. So it still does, quetiapine, even though it's preferred as an antipsychotic, it interferes with the Parkinson's disease itself and the medications. So risperidone does not make sense to give instead of quetiapine. Do you agree? Say yes or no. Do you agree B is incorrect? Do you agree? I'm saying yes, I agree with myself. Thank you. Yes. 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 C, olanzapine because it has lower EPS risk than haloperidol and treats psychosis quickly. EPS. Well, we can tell that olanzapine, is this a true statement? If you're not looking at the case, okay, this is important, guys, so answer this one. If you're not looking at the case, is C a true statement? It is. So olanzapine does have lower risk of EPS compared to haloperidol, but we need to check the patient here. What's most appropriate for this patient? Remember that we're treating psychosis from a Parkinson's patient, and we're trying to minimize worsening tremor and rigidity. So to tell you the truth, olanzapine, we don't want that. It's a dopamine antagonist. Let's look at D, pimavanserin. It says pimavanserin because it treats Parkinson's disease psychosis without dopamine receptor blockade. Is that true? Shai, you said no to something. Which one did you say no to? Oh, just C being incorrect. I think that's what you said. What about D? Is D true or false? I'm entering that in the chat. Is D true or false? Pimavanserin because it treats Parkinson's disease psychosis without dopamine receptor blockade. What is pimavanserin? Does anybody remember that? It is true. Yeah, Shai, you're right. Do you remember the brand name? I'll type it in. We learned it just the other day. Oh, it didn't come out right. From what it's supposed to be NAPLEX. NAPLEX. It keeps coming out wrong. Oh, good. Thank you. You typed it in. Thank you, Shai. That's perfect. Perfect. So D is the correct answer. Just for completeness sake, E, chlorpromazine, because it avoids dopamine antagonism and is preferred in older adults. No. Chlorpromazine does not avoid dopamine antagonism, number one, and is not preferred in older adults. So that's incorrect. D was correct. Shai, you were right. Pimavanserin does treat Parkinson's disease psychosis without the dopamine receptor blockade. It wasn't that long ago that we didn't have this option, and we had to rely on quetiapine as being the antipsychotic that could help with psychosis in Parkinson's disease with the least amount of EPS. But now we have something better, pimavanserin, which, why don't we look, ooh, oh, I meant to put that before. Why don't we look here. Pimavanserin acts primarily through serotonin 5-HT2A inverse antagonism, rather than dopamine blockade. And what I love about this is right here. I wanted to show you because I think it's too cool. This mechanism of pimavanserin is that we have this inverse agonist. Here's what we normally see and what you and I are used to looking at. We're used to looking at some agonists and antagonists. So imagine this, we have serotonin binding to 5-HT2A receptor, it activates it. And that's ordinarily what an agonist does. An antagonist, on the other hand, is going to come here, it's going to fit here, it's going to block anything to happen. So there's no change, no receptor activity here. On the other hand, we would have the pimavanserin right here. It binds to the receptor and it stabilizes it in an inactive conformation, reducing the baseline activity. So it actually has less, it has the opposite action of an agonist. So agonist will activate the receptor, antagonist just blocks it, so there's no change, where inverse agonist actually decreases baseline activity. So that's how it's different, and I'm going to leave it at that. We're going to get better at doing this. I really do want to make it that we do a few cases every day. So maybe around this time, every day, every weekday, let's give it a shot. It'll get better as time goes on. Thank you so much for joining, and we'll see you tomorrow. Take care.